I'm Jay Mead, and I'm involved with LabX Clinical Services. I'm one of the co-owners of LabX Clinical Services. Delighted to be here, and thank you for staying. We're going to discuss today the variations and variable values that one might get from the various test options that you have. I'm going to contrast and compare all three of these. As mentioned, I'm a pathologist, and these are little quips we did as medical students where the surgeons knew everything. They do everything, know nothing. The internist knows everything, does nothing, but the pathologist knows everything and does everything, but usually 3 days late. And 13 years ago, I stepped out from behind the microscope in the white coat, and I started seeing patients. And through a series of very fortunate events for me, I ended up teaching at the National College of Naturopathic Medicine in their pathology department while I was learning complementary alternative medicine. And I met a lovely naturopathic physician who I subsequently married and became a partner with in our laboratory. And I learned more at that school and from my wife than I ever learned in my allopathic medical training about preventative medicine. And the practice I have now is amazing. I do both laboratory medicine and I also see patients. And I've helped patients in ways I've never imagined. But let's talk about laboratory medicine. For some of you, this will be review, and for some not. And hopefully you'll glean something from all of this. But what happens in the laboratory, and we all know this, I knew this as a pathology resident, we were trapping sick people in a curve and using this type of statistics to establish a reference range. So if we don't talk about a specific test, which we will eventually, but let's speak to just the idea of setting a reference range. Now notice I call it a reference range and not a normal range. And I hear my colleagues talk about normal ranges when they look at a reference range in a laboratory, and I cringe a little bit because it may not be in fact the normal range. That is not the range that you want the patient to be in, but it is certainly the range that if you test a group of patients as done, for example, what is a group of normal, for example? Let's say we're looking at, we want to find normal patients. Where do we find healthy, normal patients? Well, we all know that's difficult. Where would you go? The military, perhaps? Young people in the military? Well, how does that relate to older individuals? Maybe you could go to blood donors. College students are often, medical students are often thrown into the reference range mix. So you have to be careful where you get your patients or your sample for your normal range to start with. But once you do that, what you simply do is test a statistically significant group of them, and 30 is actually considered statistically significant in for most matrices. But let's say you test 100 or 1,000. I mean, I can go into our database and I can test 100,000. I can look at 100,000 postmenopausal women, for example. Well, what you do is you get a mean. So you look at the mean of that group of individuals for the test analyte you're looking for. Let's say you're looking for TSH, for example. Anyway, you get a mean, and then you go 2 standard deviations above and below the mean, and that becomes your reference range. But note that on either end, there's over 2% of individuals who will fall out of that range but are normal, using it in the sense we were just discussing. And all of us have experienced this, and I experienced this as a resident in pathology when the young internal medicine residents or surgical residents would come down to the lab, and they'd want to know what to do with the Kim panel that had 23 tests on it, and one of them is out of range. That's common. One of them will be out of range. Statistically, 1 out of 1 out of 20 values statistically will be out of range because those individuals would either fall in, that value for them fell in outside of that reference range curve. And so I would quiet them down and tell them not to worry about it. It's probably a normal variant. Don't do a bunch of additional lab tests. Because I trained in the military where we didn't do additional lab tests unless we felt they were really necessary. So that's the scoop on how reference ranges are established. Now let's take a test, for example, that we all know is flawed. I think most of us would agree that the TSH test has a serious problem. We have a reference range in most labs starts about 0.4 on this end and goes up to as high as 5, for example. So you have a huge range of TSH levels for individuals. And I see endocrinologists all the time who will turf somebody with a 0.5 TSH, 4.8 TSH, for example, and they have every symptom of hypothyroidism, but because they're within the reference range, they're not treated. And that's unfortunate. Now, I hope all of us here would try to lower that TSH level, if you measure TSH at all, and it's one of the worst tests ever created, frankly. But for MD, such as myself, I need to have a TSH in the chart in order to satisfy my board if they start reviewing my charts. So I do a TSH level, but I pay little attention to it. In fact, it's another lecture, but you can have a low TSH level and be hypothyroid. Stress will reduce TSH production by itself. So a TSH level is fraught with all sorts of problems. So what we want to do is optimize levels, of course. And as you know, over time, reference range values do change because we start to understand that what we established as the reference range was too broad.